So do you have any personal experience with people displaying drug-seeking behavior, or you're not sure if they're displaying drug-seeking behavior?
I do. I mean, I have. Certainly several of the places I've worked, most pertinent to here would probably be at Lowell Community Health Center, where I was the medical director for a while, and it was a new doctor started, and pretty quickly he sort of developed, attracted the attention of several people who came in looking for drugs. It was almost like there's a new guy in town, let's try him. And this doctor hadn't had a lot of experience with that sort of stuff, and was pretty quickly overwhelmed with the demand for people that you have to give me my pain medicine, you have to give me my pain medicine. We worked together a lot to try to sort out who seemed legitimate, who's not, how you would do that. And we actually worked, and this was a while ago, worked with a pain specialist who was very helpful to help us first, help him and I sort of help figure out who was obviously, just looking for pills, who was obviously, had genuine pain issues, and who were in that big gray middle at how to figure out what to do with those folks. And with that pain specialist, we developed a protocol for the doc to use to sort of ask some specific questions, to put some very specific expectations on people's behavior going forward. If I give you a pill, if I give you a prescription, it's going to be for a small amount. You're only going to get medicine from me. You're going to come back and see me in a timely fashion. You're only going to use one drugstore. So they're fairly common behaviors that doctors learn to put into practice. And at the same token, if I have any questions, the doc had any questions about whether your pain is legitimate or how to handle your pain, I am going to refer you to a pain specialist who himself has a lot more experience with this sort of thing. So we sort of incorporated that doctor into the practice, even though he wasn't physically with us. And that was very helpful. It really helped give the prescribing physician and me, his supervisor, some clear tools to put in place to sort of help us sort out the folks who seemed kind of legitimate from the folks who didn't seem kind of legitimate. But obviously, if we've known somebody for a long time, they developed cancer, they had pain, that wasn't an issue. But somebody we don't know at all just shows up and says, I need, oxycodone because I need it. And it helped give this doc, who didn't have that much experience, the tools I think he needed to put in place to help both sort people out, deal with them himself, and it gave him a lot of comfort to have somebody behind him that had some expertise that he could work with to create an effective plan for each individual patient.
For pain, which is many times an affliction that you can't necessarily see a visible wound,
right,
or something like that, how difficult is it to determine that
it can be very difficult. If you have, as I said, if you show up and you have a long medical record from somebody I know that says, yes, this poor man has some sort of underlying major problem that's going to give him pain for the rest of his life, that's easy. If someone shows up out of the blue, you don't know them, they don't know you, they say they have pain, part of the issue is trying to figure out what it is, what else can I do to fix this, not just cover it up with pain medicine. And then how much pain medicine do I need to give you, and of what sort, to help sort of ameliorate the symptoms while we figure out if there's a way to fix this. So it can be very complicated. You can certainly have a gut sense of, gee, this person's trying to pull one over on me, but people who look disheveled and disorganized have pain too, and can certainly have chronic issues, can have back pain, can have old injuries, can have a lot of things that aren't so visibly obvious. So you have to sort of take everybody individually, create sort of work through, have a systematic way of addressing people who show up in your office with this complaint. Try as hard as you can to get more objective evidence than my sense of you is that you're on the up and up, or my sense of you is that you're not legitimate, because you really can't go by how somebody looks. People who look very, very organized, very put together, very intelligent and intact, can still have an issue with addiction. People who don't look very organized, don't look very intact, can still have genuine reasons to have a significant amount of pain. It's very hard to sort of take the subjective presentation, but that's my job, the doctor's job, is to take that subjective presentation and work it down to something that's fairly objective, fairly rational, and something that both I and the patient can work with going forward.
Does the prescription drug monitoring program play into that as all as a tool?
Not yet. It could, it should. I think in other states it does. But that's really only going to be useful when it's very easy to use, very real time, and and it's reliable. I mean, I was thinking of this as I stopped for gas earlier today. I pulled up to a gas station, wanted to get gas, put my credit card in, and wanted my zip code. It liked my zip code. It gave me the gas I wanted. It should be that easy for us to at least know who we're giving these prescriptions to. You know, all this information about your old prescriptions is on record somewhere. It's not going to tell me whether you have a legitimate complaint if you've never seen anybody before, but it will. In Connecticut, for example, there's a fairly robust system that will at least tell me how many narcotic prescriptions have you gotten, who have you gotten them from, how much are they, sort of how much outstanding narcotics do you, in theory, have in your possession. And that will give me some perspective on whether you're some person who only gets prescriptions from an oncologist and has been to that oncologist 7 times, and you happen to be with me today because that oncologist is out of town, or you're somebody who's been to 7 different doctors for back pain in the past 12 hours and have gotten 7 different prescriptions for each of them. You know, it doesn't get you into the person's detailed medical record, but it should at least give me a clear sense of what your sort of recent prescription behavior has been, and forces me to take that into consideration when I decide what to give you for a prescription. Right now, I think that from what I get from folks who actually use the system is, yes, everybody in Massachusetts now has access to it. We're all, as we get our medical license, are supposed to also be signed up for this, so I can, if you come to me for a prescription, go online and look you up and get some sense of what your, opioid prescription use is. But I don't think it's very real time. I don't think it's very easy to use. I don't think the system's in place to delegate this, because certainly in a busy office practice, whether you're an orthopedic surgeon, an oncologist, or a family practitioner, odds are I'm not going to be the hand that goes to the computer and looks this up. I will have delegated that to somebody that I trust, that I'm responsible for. And I think we need, and I don't think we quite have that yet, a clear system for me to delegate that responsibility to X person who will keep that information as private as they keep everything else in my office, and who will get me that information, and then I'll be responsible for using that information. You know, it doesn't tell you whether this person is righteous today or not, and people who've had problems with IV drug use develop cancer and now they need medication. People who had a problem and the problem is over and now they're still coming, and then they're still coming back looking for medication. It's not going to really tell you exactly what's going on with that person across the table from you at that point in time. But a robust system which should be available with the state of software and computers nowadays. There should be an app for that or something close to that, where I can put your information in and get feedback right now. This guy has had this many prescriptions at these many pharmacies, and it should be pretty close to real time, because certainly the information is out there. The large corporations and the prescription benefit managers that sort of feed them information and get information from them can tell pretty much in real time whether you just walked out of a Walgreens someplace, or you just came from 2 CVS's across town or not with prescriptions in your hands. That information is out there and it's available. It should be put into the hands of the people that are responsible for pushing things out, because certainly the opioid epidemic that we have in our hands today is not all about prescribed medications, but a good chunk, and you see different numbers, but a good chunk of the folks who have a problem with opioids started off using prescribed opioids one way or another. Either they used somebody else's medication or they got it from themselves. And I think the prescribers of the world, physicians, nurse practitioners, dentists, chiropractors, anybody who has the ability to prescribe medication, I think has some responsibility to try to reduce the amount of inappropriate prescriptions that are out there. I think you asked, I haven't had the experience about getting opioids prescribed to me when I didn't need them, because I haven't had that, frankly. Thankfully, I haven't had those sort of medical conditions, but I have a friend who was a gentleman who used to run the state's substance abuse service, the BSAS, I think it's called, who now works for the federal government, who is happy in public settings to tell the story on himself, that he himself is a recovering, I don't know if he's an addict or an alcoholic, but he has a substance abuse issue, and he talks about getting a dental procedure and having the dentist hand him prescriptions and him saying, no, I don't take narcotics, I don't take opioids, I'm in recovery, and the prescriber insisting that he take it away, and him really having a hard time rejecting those sort of prescriptions. Obviously that doesn't happen every time, but I think that happens far too often. And it's always it's the easiest thing for the poor prescriber to do, to give you something for the pain, because I know you're not going to, once you leave me, you're going to have some pain. Here, this will take care of it. We probably need to, as a group, as a very big group, learn to be more conservative with how much we hand out, what we hand out, when we go for something very strong versus something not so strong. There used to be a big sort of social prohibition about giving out narcotics, and that with the introduction of some of these longer acting and more addictive substances, that prohibition has sort of melted away. That has not been good for us as a society or as individuals. And I think the idea would be to go back a little bit and be somewhat more, not proscriptive, but thoughtful about when we use something that's addictive, what we use, how much we give away, how soon we're going to see that person again, and not just be giving people narcotics willy-nilly because it'll keep them happy and it'll keep them off my door. I think I and the doctor that worked with me at the community health center learned that lesson several years ago, and I think that's the kind of lesson that I think as a group, prescribers need to be relearning constantly.